going to start recording here. And welcome to everyone. Thank you for joining me, all 25 of you, it looks like, so far. I'm always surprised I even get that many people to show up for these things. But I think having real live interactions is very helpful. Hey, Cassette, how's it going? So anyway, so I had a couple questions that came up about the drug information assignment, and so some of them I'm getting multiples of those, and so it's good because people have questions and I want to be able to address them for everyone. So anyway, first one here, for the drug assignment, do you want us to put doses for pediatrics, renal patients, etc., or just adults? Also, are we basically copying what we find in lexicon for most of this? I wouldn't say, Brian says he's looking forward to my witty comments, as if I have any of those. They're all gone. No. So you're not copying straight from lexicon, because I don't think that really does you a whole lot of good just to copy and paste. The exercise is more so about being able to find the information, and you may not understand all of it at this point, but hopefully some of it is becoming a little more discernible. So when you read things about like renal dose adjustment, now you kind of know why we have to do that, because we had the kinetics talk last time. So, when you're talking about like drug doses for like renal patients, that's going to be more important for when you're dealing with questions of like, okay, well, you have someone with altered kinetics, how would you adjust it for someone who, is a renal patient, they're on dialysis or something like that. Generally for dosing though, just stick with adult dosing. And if you have like a lot of different indications for your drug, just put like one or two, I think is totally reasonable. You may even want to consider putting like, what's a normal dosage range, right? Independent of the indication, like what something a normal dose might look like. And so that's one of the things too you'll get a feel for as you go along, of like kind of like what's a normal dosage of a drug, what's an abnormal. Is it something that when your patient says, I take this much of this drug, does that sound reasonable, or does it sound kind of totally crazy? And a lot of times I'll have patients that will say, I'm on 300 milligrams of this drug, and I'm like, well, one, it doesn't come in that strength, and two, that's a really crazy high dose. A lot of times it just happens to be that they have mixed it up in their head and they're thinking about a different medication they take, right? So that's kind of what I want you to get a feel for that one. And then someone else had asked for number 6 in the drug assignment, do we need to calculate the CSS in order to find this? And just FYI, I apologize if I have any internet connection issues. That is... I think it's the weather probably not really helping me out here. I am recording this, so I will post up the recording, so that way it should be pretty clear if you want to go back if you miss anything. But anyway, so they're asking, do they need to actually calculate CSS to find this? And you really don't, right? Because the CSS is going to be a factor of that half-life, but also like how much dose are you putting into the patient. So the dosing in the interval along with that clearance is what really helps to dictate the CSS. So you'll find that the half-life contributes to that, but you really don't need to. So let me go back to the question actually. So if you look here, number 6 is based on the half-life of the drug in a healthy patient, how long would it take to achieve steady state? So you don't have to calculate a CSS because it may be different depending on like how you're dosing it and like who you're using it for and things like that. But roughly it's 4 to 5 half-lives. So it's actually just as simple as saying, well, it's 4 to 5 times whatever the general half-life is for that particular drug. So a lot of this stuff may seem like, well, this can't be this easy, right? And it kind of is though, because it's a simple drug information assignment. I'm just getting you used to looking these things up and being able to find information when you need it, right? So anyway, so those two have been addressed. And let's see. If you have any other questions, though, feel free to post them up in the chat or on the sticky board, and I'll address those a little bit later. But let's get into the topic at hand. Let's talk a little bit more about bioavailability. This is actually going to be a little bit of a different, it's kind of hodgepodge of topics. We'll also talk a little bit about drug safety. We'll talk a little bit about adverse reactions. We're going to talk about actually some basic math that you need to know in order to be successful, not just for my course, but also in general in terms of medicine. Like what do you kind of need to know? And hint is it's actually not a whole ton. If you can do basic algebra, chances are you're going to be just fine. So anyway, first I want to talk about the differences here between like adverse reactions and side effects. And you may hear people sort of talk about them interchangeably, but there is a bit of a difference there. When we say adverse reaction, we're really talking about any sort of like unpleasant or like harmful reaction that a patient has as a result of using a medicinal product, right? And so based off of the hazard from giving the patient future doses of that drug. It may require us to do things like initiate certain specific treatments. It may require us to alter the dose we're giving the patient, or it may even require us to stop giving the drug at all. So I'll give you a good example of this. Imagine you have a patient who has like rheumatoid arthritis and they have to be infused with a drug called infliximab. Another name for that, the brand name is Remicade. It's a protein-based drug. It's an antibody that we actually inject into the patient, and it helps to reduce inflammation. Well, because it's a foreign protein that we're injecting into the patient, what you end up finding is that you're likely to have a reaction to it, because your body may have reactions to foreign proteins. It sees as like an allergic sort of reaction there. And so we know that's a risk, right? And so in some cases, we actually will pre-treat patients to prevent an allergic reaction from happening. So sometimes they'll get Benadryl, sometimes they'll get steroids beforehand. And we also want to have things available. So that way, if they do have a full-blown anaphylactic reaction, we can give them epinephrine, for instance. Don't worry about memorizing what drugs you're going to give for an anaphylactic reaction. We're going to talk extensively about that in the upcoming courses, right? But in some cases, if we know a patient is likely to have a reaction or they've had previous bad reactions, we just stop the drug altogether, right? Because we may not need that drug. We may be able to switch to something else potentially. So these are all things we're kind of thinking about when we're giving drugs. It's not just how well it's going to work for the patient, but also what are the inherent dangers that could occur with this patient getting it. And so you can kind of break down these adverse reactions into, say, like 6 different sort of categories. So I kind of have them broken down into this sort of A, B, C, D, E, F mnemonic here, but basically we can call them either dose-related, non-dose-related, sometimes they're dose and time-related, sometimes they're just time-related, there's withdrawal, and then failure of therapy. So I'll talk about these specifically in the upcoming slides here. So first off is going to be this dose-related or augmented sort of reaction a patient can have here. So these are fairly common, and typically these are related to the pharmacologic action of the drug, so the actual mechanism itself. And these things are predictable, and because we can predict them, they're generally low in terms of mortality. And this typically includes a lot of like sort of the more minor and bothersome sort of side effects. I'll talk a little bit about the difference between those in just a little bit. But for instance, if I were to give someone diphenhydramine or Benadryl, I know sedation is going to be a common side effect, and I know that can be a dose-related sort of effect, such that if I give, say, a half dose to someone, maybe that will treat their allergies, but they don't get so sleepy. If I were to give them a full dose, then yeah, I know they'd be out for the night, for instance, right? Or if I'm going to give like an antihypertensive, like a calcium channel blocker, I know that if I increase that dose, I'm increasing my risk for hypotension, right? You can see the same thing with bleeding and a blood thinner. You can see the same thing with hypoglycemia and insulin. It's all related to the actual mechanism of action of the drug, right? So then you get into these like non-dose related or sort of bizarre sort of reactions. You can't sneeze when you're unconscious. Actually, I can't say I've ever seen an unconscious person sneeze before, but that would be quite interesting. We'll have to do some more research into that, see if that's possible, right? I know you can't sneeze with your eyes open. I hear your eyeballs just pop out of the socket, but that may be an urban legend. But don't try it at home. I don't want you to do that. Anyway, so then getting into some non-dose related, these are going to be things that are uncommon, right? And sort of like not necessarily related to the pharmacologic action of the drug itself. And as such, we can't really predict it as well. And it tends to have a higher likelihood for things like mortality potentially. So I can't look at a person and know if they're going to have an allergic reaction to a penicillin, right? Sometimes you don't know until you give the drug and find out. Another good example of this one would be a condition called malignant hyperthermia. And so this is something that can happen with certain general anesthetics and a paralytic drug called succinylcholine. And so some of you who have had experience with like the OR or in the ER setting, you probably run into some of these drugs here. And this is a really rare condition that happens. You have to have a certain genetic polymorphism that makes you at risk for developing this. And so this is why like screening questions are really important. So if you can ask a patient, hey, has someone in your family ever had a really bad reaction to anesthesia? Sometimes that can clue you in to say, oh yeah, my grandpa died on the operating table after getting such and such drug. That may clue you in to be like, okay, well, this person is at high risk. Maybe I should test them prior to giving them one of these. So sometimes you can do some history here, but a lot of times you just don't know, and so you don't know until you actually give the patient the drug, right? Sometimes things can be dose and time related. These are relatively uncommon, but are more so related to sort of like the cumulative time and the dose that a patient has been on a given drug here. So a good example of this is corticosteroids. So I'm sure you've covered lots of negative feedback loops in physiology with Professor Kaplan, but we know that if you were to say supply the body with exogenous hormones, typically they're going to shut down production of those hormones themselves within the body, right? So if I give someone, for instance, testosterone, their testes are going to atrophy because they don't have to produce their own testosterone. Well, the same thing happens here with corticosteroids and the adrenal glands. And so if you give someone, say that same rheumatoid arthritis patient, if they're on corticosteroids like prednisone or something for long term, the adrenal glands actually start to shut down production of cortisol. That's normally fine because they're taking these exogenous steroids, but what happens if the patient, runs out of their dose or they stop it abruptly? Well, the adrenal glands can't really catch back up immediately. It takes some time for them to start production again, and your patient can go into an adrenal crisis, right? They can go into adrenal insufficiency. And so that's, again, related to not just the dose they're on, but also the amount of time. So if you can reduce either of those, you can help to reduce these adverse reactions from happening. So if you get like a 5-day course of, prednisone for an asthma exacerbation, that's not going to be a problem. But if I'm on it for years because of rheumatoid arthritis, that's a whole nother story, right? Next, you get into the time-related ones. These are things that are not generally related to the dose that the patient's receiving, and they only really become apparent when they've been taking the drug for like a long period of time, right? As I was mentioning, some examples of things that only really become apparent after a prolonged period of time would be something like teratogenesis, and that's basically any sort of like birth defects that occur within a fetus as a result of exposure to a given drug. So, for instance, imagine you have someone who is taking a drug called valproic acid or Depakote for a condition like bipolar disorder, right? You will find that if they become pregnant while taking that drug, because not everyone knows when they become pregnant right away, you end up having this drug exposure occurs during organogenesis, during that first trimester, and they can develop these neural tube defects, right? And so that's something we wouldn't know about until potentially further along in the pregnancy, right? Another good example would be things like tardive dyskinesia that you can see with certain antipsychotics. And so this is a condition that happens over a long period of time in which patients start to develop these sort of abnormal movements, and they have certain tics and things like that. They have like tongue smacking and things like that that can occur with time. And so that's going to be an issue you can see with that after prolonged period of time and prolonged use of the drug itself. Another thing would end up being with withdrawal. This is something that can happen when patients stop taking a medication, and they generally have sort of withdrawal phenomenons that can occur, usually the opposite of whatever would happen when the actual drug itself was there. So for instance, if you're taking an opioid and you're causing having constipation from that, and then you stop taking the drug, well, then you can have diarrhea as a withdrawal effect. A lot of cravings and things like that can occur here as well. You can see that, depending on the half-life of the drug, you can actually find that using a longer half-life drug actually helps to prevent some of those withdrawal phenomenons because the actual levels start to go down sort of at a slower time frame. Looking at a beta blocker withdrawal, and actually there's been cases where abrupt withdrawal of that drug has actually led to MIs before, right? Because the heart became extra sensitive due to the upregulation to things like epinephrine. Take that drug away, all of a sudden the heart rate's going like crazy, and you're using up all this oxygen. It just outstrips its really the supply that it has due to coronary disease and whatnot. So anyway, so withdrawal is another uncommon, but you'll still see it from time to time, right? Sometimes you're going to have failure of therapy, and so this can be related to several different things. It's a pretty common thing too. You're going to find this. It could be related based on the dose that you're actually administering to the patient. This may be related to drug interactions too, right? So say, for instance, you're treating someone for an infection, right, and they are taking a fluoroquinolone for that infection, and then they take it with an antacid like calcium carbonate or something, Tums. That actually will bind up the two together and prevent it from being absorbed. So you can talk to a patient and say like, wow, wow, your infection seems to be progressing. Maybe they just came with like a regular UTI and now it's like turning into pyelonephritis or something. And you're like, okay, well, were you taking the medication like you're supposed to? And like, yeah, I took it like I was supposed to. But if you don't uncover that interaction was there, then you could lead to thinking the drug didn't work when really it just never got absorbed in the first place, right? Or sometimes, as a good example, when you have like an enzyme inducer on board, and that is actually causing upregulation of enzymes, which is metabolizing drugs more quickly, and that can lead to failure of certain things like oral contraceptives, right? And so if the adverse reaction was you got pregnant, that would not be great for a lot of people, assuming that was not a planned thing for them. So even things like that we can still consider to be an adverse reaction in terms of being a failure of that therapy, right? So when we're talking about side effects, typically these are regarded as undesirable, not always the case, as you may see, and may be related to the desired therapeutic effect, or it could be completely unrelated, as the case may be. Sometimes it can be good, though, as I mentioned, like the drug bimatoprost, or Latisse is the brand name. Actually, I had that mixed up. It was originally used for glaucoma, but they realized they have this like increase in eyelash length, right? So it's like, you had these glaucoma patients, and all of a sudden they have these like really long, luscious lashes, and they're like, wow, this seems pretty cool. So like maybe we can use this for aesthetic purposes, and so that's probably far and away the much more common thing you'll end up seeing bimatoprost being used for. Although an undesirable side effect is that it can turn the iris brown, so it may not be as favorable for someone, say, with like blue eyes, but if someone like brown eyes, they're like, well, what do I care? They're already brown, right? So to give an example of, say, a difference between like a side effect and adverse reaction. So like a side effect, say the patient was taking the drug sulfamethoxazole, trimethoprim, or Bactrim. A side effect may be that they have a little bit of photosensitivity and they have rash and urticaria on sun-exposed areas, right? That's something you can get around by telling the patient to make sure to cover up or use sunscreen, things like that. But an adverse reaction, much more detrimental reaction, could be something like Stevens-Johnson syndrome, which is the same drug can do both of these things. One is obviously much more rare, such that we wouldn't give every patient if they had a good chance of causing Stevens-Johnson's, because you can see here all the skin is starting to slough off of this patient as a result of the condition here. And so this can be fatal if the patient's not caught early and managed for this. So just to give you an example, kind of the difference between like a side effect and an adverse reaction. Here is one with the drug Viagra or sildenafil. So like a side effect may be as a result of the smooth muscle relaxation the drug causes. You can get an upset stomach because it's loosening up the lower esophageal sphincter, right? An adverse reaction, though, is sudden loss of vision. Not great, and sometimes that vision loss can be permanent. So it's like, okay, well, that's definitely a bad thing. Obviously, this is much more rare to occur because we still use the drug and we still give it to plenty of people. But you're going to find that that's kind of like the line there, right? So is it something like, debilitating? Is it something potentially really detrimental? Morbidity or mortality from that standpoint. With lisinopril, which is an ACE inhibitor, here's a side effect like cough that can develop, and this is a result of the mechanism of the drug actually building up a product called bradykinin. And sometimes this cough even, this is like kind of chronic dry cough, and this is annoying enough to patients where they may want to stop taking the drug altogether. Or I had a family member who had to stop taking lisinopril because his wife was about to kick him out of the house because he kept coughing and keeping her up all night, right? On the other hand, though, like an adverse reaction would be angioedema. So imagine if you were taking a drug and your tongue became that swollen, it was sticking out of your mouth along with other parts of the airway. That's going to be a problem from a mortality standpoint real quick if you don't get an airway actually secured there. I've had patients like this come into the ER. Their airway is so compromised, and obviously, trying to do laryngoscopy on this type of patient would be nigh impossible. And so we actually end up having to use a fiber optic scope and actually using a nasal airway there. So basically, scoping down using a fiber optic scope and basically putting a tube through there. So that's kind of an interesting way to do that. Getting a little bit into that drug safety. So let's talk about the 5 rights. Some people talk about the 7 rights, but these are kind of the more common ones. When we're giving medications to patients, you always have to make sure that you're doing these things, right? And some of this stuff is like, no duh, like obviously I should use the right drug on the right patient, but medical errors happen way more common than what you actually think are out there, right? And so if you actually look at, I'm glad that worked for you. If you're actually looking at the number of medication errors that are out there, it's actually pretty astounding, as you might find. But anyway, so looking at some of these and talking about some of the pitfalls you might run into and some of the ways to actually get around those. So with the right drug, like you think, okay, well, you should always pick out the right drug, right? But people make mistakes sometimes. And I'm not sure if you guys have ever heard of the Swiss cheese model, but this is one we frequently talk about in terms of medication safety and making sure that, if you think about you as a provider, you're not perfect. Everyone makes errors. You can kind of think about yourself as a slice of Swiss cheese. You have holes in random spots, right? And so presumably if you were to then line up two pieces of Swiss cheese together, well, the holes shouldn't necessarily overlap there. So imagine that's going from like the provider who's ordering the drug to the pharmacist who's getting that order. I should be able to catch a lot of those errors that occurred there, right? Well, sometimes those holes do line up, and so maybe it gets past me, and then hopefully the nurse is going to catch that error, but maybe she doesn't, and then now the patient's gotten the wrong drug, right? So we're trying to prevent that and try to eliminate as many holes as possible. But I'll tell you about a good example of an error we ran into a few months ago at the actual hospital where I work over at Nemours. So anyway, so first off, was starting with the right drug. You can have different brand names. You can have the same brand name with various like letters on the end of them, and they all denote different things, right? So there's XR or SR or ES, and they all stand for different things and all have different release characteristics. And so I can have a patient tell me, like, a good example is Wellbutrin. There's Wellbutrin XL and then SR. It's an antidepressant drug, and so the XL is only given one time a day. The SR is given twice daily. So if I screw that up and the patient is on SR and I assume they meant XR, then they're only getting half the dose a day because I'm dosing one time a day, right? Or if I do the opposite, they could be getting a double dose. Obviously, that can lead to some issues, right? On the other hand, though, imagine like a lot of over-the-counter products, things like NyQuil, Tylenol, just doesn't mean it has one drug in it. It could be a combination of various things. And so it's really tough. Like I was on call for the Poison Center just the other night, and they said, the patient was, they took some NyQuil. And I was like, well, which NyQuil product was it? And they're like, we don't know. Well, that doesn't really help me because I can assume there's certain things in there, but was there Tylenol in there? Was there phenylephrine? Was there chlorpheniramine? They could have any or all of these things, and that makes a big difference in terms of looking at drug toxicity because, maybe I need to worry about a Tylenol overdose now. Maybe I need to worry about some pathomimetic overdose at this point. So there's a lot of things that go into that. But not only that, but imagine, say, for instance, in the future, one day we may be able to travel again. At this rate, I have no confidence in that. But let's say this is the pre-COVID times and there still was travel happening. You get a lot of people coming into the state because, again, we're the land of the mouse. You get a lot of people with foreign medications there. So if you're dealing with someone from the UK, for instance, they will call albuterol, which is their typical like asthma inhaler, they'll call it salbutamol. And if you didn't know that, you wouldn't know what drug they're taking. Or paracetamol is the British version of acetaminophen, right? Or actually, one thing I would frequently run into in the ER is I would have a lot of patients coming from South America, and so if they're coming from Brazil or if they're coming from Chile or all these different places, they may have various languages on their medication bottles. And guess how I had to figure that out? Well, Google Translate really saved me on a number of occasions to be able to convert that over and figure out what they were taking. Sometimes you could figure it out based on certain context clues, but a lot of times I just had to Google it and figure out what the heck they were taking. But again, getting that right drug can be hard. Name alerts for getting the right patient can be really important too. If you go to any ER, you may find 6 or 7 Smiths, and then there's 4 Rodriguez's, and there's a lot of name overlap there too. And so it's important to make sure you get the right patient each time. This is where we do a lot of things like barcoding, so that way when you're scanning, or the nurse should be scanning to make sure they have the correct patient there. Especially if like multiple siblings like all in the same room, that can be really tough too. Not only that, but imagine if like a person doesn't even have a name yet. And you're like, well, how could a person not have a name? Imagine they were just born, right? So if you have someone, say, for instance, they have twins that are born and they get transferred over to our NICU or neonatal intensive care unit, you may have twin A and twin B. Like it's literally how our computer system will have their names. And so what's really kind of frustrating too is that we frequently have twins like that. You want to keep them in the same room because it's just healthier for them, and so they'll have a bed A and a bed B, and I swear to you they do this on purpose, but they'll put twin B into bed A and then twin A into bed B, and you're like, well, this is just setting ourselves up for errors here, right? Because one of the patients may need more or fewer medications, and that can lead to some issues in someone getting something they don't need or not getting the thing they need, right? And then even patients moving around the floors, like, especially in the ER where there's a lot of turnover, you can say, hey, give that med to bed 13, but bed 13 may have changed over 3 times between the time you wrote an order to when the patient's actually supposed to get it, right? So they can move around places, they go to imaging, they come back. There's a lot of movement, and so you want to be really specific in making sure you get the right patient. So I'll give you an example of a medication error that we had to deal with a couple months ago. So we had a GI doc, and they were giving a medication in the special procedures area, and they were doing a gallbladder stimulation test. So basically, they would give them a drug to stimulate the gallbladder and determine if there's any issues there, right? And so they had 3 patients in a row that were supposed to be getting this drug, the stimulant drug. And so, we get their first order, and back in the IV room of the pharmacy, they make it, and it comes out to be delivered, right? Be delivered to the OR, so that way the doc can give it. In this case here, the anesthesiologist was actually the one administering the medication while the GI doc was doing all the whatever other monitoring they were doing. So, so for whatever reason, that medication for that first patient never got delivered, right? It got buried somewhere. Okay, it sometimes happens, right? It's an error on our part in the pharmacy. So then the next order for the second patient came through, which is a different size patient altogether, right? So they require a different dose. They ended up that we got the second order, we made it, and that one did get delivered. Okay, but it got delivered into the room where that first patient was. Okay, so now we have the medication for a different patient. And we have a different patient right there in front of the anesthesiologist. So ideally what would have happened is the anesthesiologist would have read the name on the label, and they would have read the name of the patient in front of them and realized there was a discrepancy there. Well, that didn't happen, right? So now we got those 2 holes of Swiss cheese meeting up here, and now the patient got the wrong dose of medication. Okay. Now again, this is a very low dose of the medication. There's very unlikely to be any side effects from this, and there were none. But still, that's an error, right? Not only that, but to add insult to injury, we ended up giving the drug for the third patient to the second patient that was there, and again, no one looked. So overall, we had 3 medication errors that happened as a result of this one medication being lost in the pharmacy, right? And so again, you hope all those holes of Swiss cheese won't line up. In that case, it did. No harm done to the patients, but again, we had to go and explain to the families and be like, hey, there was an error here, X, Y, and Z, and so it was it's a frustrating thing. Good thing no harm came about it, but you can see how these issues pop up, and that's an easy one to happen. There are much more ways that people even like circumvent safety systems, like they'll not barcode scan a patient until after they give the medication, and then they get an alert saying, oh, this was wrong. I was like, well, why didn't you scan them first? And it's because people look for efficiencies. They're in a hurry. There's a million different reasons for these errors to happen. So this is why we got to be really careful, and why I'm trying to teach you this stuff now. Getting to the right dose of the patient, right? So when you're evaluating a patient, making sure you're taking into account any factors which may be really important, which some of you might be seeing in terms of your drug assignments now. Like, do we have to consider the age of the patient, the hepatic function, etc., to find out, is this the right drug for the patient, right? And one of the big errors that happen, this happens all the time in every hospital, is that you can have the medication reconciliation process can be faulty, right? So patients recalling what they take and how well they can do that, because patients forget things or they mix up different things. So when you do that medication reconciliation, frequently it's the nurse doing it who doesn't have a strong pharmacy background. They're writing down things into the chart of what the patient's taking, and then you as the admitting person will then reorder that stuff. If you're not taking a really close examination of that, very easy for a patient to get the wrong dose, right? I've seen cases where a patient was going to get 100-fold dosing error. Actually, the order came to us and we caught it because the dose was transcribed incorrectly, right? Here's another good example of the drug methadone. Methadone is frequently used for patients who are trying to deal with opioid use disorders and try to come off of it. Well, not all patients are honest with us, and sometimes, which is unfortunate. But there's a case in a hospital where the process is that pharmacy technicians were actually doing the medication reconciliation process, and then that was verified by a pharmacist, and then that would then go to the providers to either order or not order, right? So we had a patient who is not at our hospital. This is a different institution, but there was a patient who was on methadone, right? And so when the pharmacy tech came around, they said, hey, what dose of methadone do you take? And he said a dose that was pretty high, but not outside of the realm of possibility, right? So the tech wrote that down. They don't really know because they don't have a strong clinical background, and that goes to the pharmacist. And the pharmacist looked at it and said, well, it's high, but it's not unheard of. I'm going to go ahead and say this looks good. Now, what should have happened, they should have probably called the clinic where they get their methadone, or should have done some secondary checks. Nowadays, that's easier. This is before we have some of the systems we have in place now in Florida. But basically, it got checked off and said the pharmacist said it looks good, and then it went to the provider. Provider said, okay, that's what they said they're on at home. I'm going to go ahead and reorder that. Well, the patient was lying, and it was actually, doubling the dose that they would normally take. So what happens, they get admitted, they get that dose of methadone, and then in the morning, they are extremely somnolent, unable to be aroused, and had to get a dose of Narcan to wake them up. Ultimately, no harm was done, but it was a case where, just doing a single double check would have been able to catch this, right? So again, errors happen all the time. Not to scare you, but you're probably going to make an error yourself one of these days, and hopefully you'll learn some of these techniques to try to prevent that, okay? The right route is super important too. You may think, okay, well, oral medication can't be that hard to figure that out, but there are some instances where issues can happen. So, for instance, we'll learn about in the case of a chemotherapeutic drug called vincristine, we use this for cancer. It's lethal if given intrathecally, right? So given into the spinal column, and you're like, okay, well, that'd be really hard to screw up and give intrathecally, and if you're normally giving intravenously. Well, what happens is that frequently when they're getting this drug, they're getting other drugs that are given intrathecally. So you can imagine if you mixed up the syringes, you can accidentally give this drug. So we put safety features in place to prevent this, but just to give you one example there. Sometimes we do use drugs in a non-traditional route. Like, for instance, we can use the drug docusate or Colace, which is normally used as a laxative. We can actually put that into the ear, and that actually helps to emulsify up some of the impacted cerumen. So you may see that in the ER where you'll try to put that in the ear, kind of loosen up that earwax, and then you can flush it out, right? So non-traditional, but something you may see. Or very rarely would you ever give an oral product intravenously, but there's a case where for a period of time, the drug we use for Tylenol overdoses, we had to do just that essentially, right? So, giving medication via the wrong route can also lead to significant tissue irritation and necrosis. So, like if you give the drug phenytoin, which is an antiepileptic, intramuscularly, cause significant damage, or even vitamin K, which you think it's a vitamin. How bad can it be? If given intramuscularly, it can actually cause significant hematoma, right? So, all these issues can pop up if you are giving it via that wrong route. And then the right time is really important here too. Certain medications, their timing has to be very exact. Many medications may not really matter, right? So for instance, things like acetaminophen, if patients are taking it too frequently, that can lead to some hepatotoxicity. And this is why you always have to warn patients about not taking too much, or realizing that a lot of pain medications have Tylenol in it. So that way, if they're getting, say, Percocet, which is oxycodone and acetaminophen, making sure that they know, don't take any outside acetaminophen from this because you can damage your liver, and they're taking it too often. Or if they're taking their pain medications too frequently because they're having untreated pain, that can lead to significant sedation, right? Or imagine someone was trying to use an emergency contraceptive, right? So say there's a case where someone had unprotected sex and was concerned with pregnancy, and they want to make sure that doesn't happen, that there's no conception that occurs. Well, if you take emergency contraception, things like Plan B, too late, that can lead to failure too, and that can lead to an unintended pregnancy, okay? Or say we're giving antibiotics too infrequently, that can lead to worsened infection and resistance. So sometimes timing can be extremely crucial to some of these medications working appropriately. So up next, we'll see a few different definitions here. We talked about these briefly before, but I just want to kind of briefly touch upon bioavailability. And when I talk about bioequivalence, basically what this means is that when you imagine having a brand name versus a generic drug, one of the things that they have to do is when they want to bring out a new generic drug, they talk about things being bioequivalent, or essentially meaning that they're the same strength, they're the same concentration, the dosage form, everything is exactly the same, such that they work the same in the patient. And so generally when they're looking at that, when the FDA wants to approve a generic drug, they have to show via pharmacokinetic studies that the generic drug is going to be within the same realm. So there's usually certain percentages they have to be within in terms of drug levels to make sure that they work just the same as brands. And again, when you have patients that say, oh no, the brand name is the only thing that works for me, the generic doesn't work, frequently that's usually in their head because they couldn't really be out in the market unless they showed that, yeah, they are working just the same as the brand name. There are some cases where that is true, but for the most part, that's something that patients are just thinking, and it's not really the case. But But when you're looking at bioavailability, which we talked about a little bit before, recall that this is altered by many different factors, right? So that way, I can know that something like rectal absorption may be very different for a drug than, say, oral absorption. And a lot of it can be, features of the acid-base status of the solution the drug is in, the actual physical properties of the drug. All these different things can really have an effect on the bioavailability of that drug itself, right? And remember, obviously, IV is going to always have the best bioavailability. IM, sub-Q is always going to be pretty high, but oral, can be completely variable, right? So depending on the drug, you may find it could be close to 0, it could be all the way to 100%. Just depends on the individual drug itself, right? And so, if you recall, I just wanted to touch on this acid-base sort of review again, just to make sure we kind of understand the process here. Remember that as we change the solution that the drug is in, whether it be in the stomach acid or whether it be in the small intestine or other places, you can really affect the ionization state of that drug and either help it or prevent it from being absorbed across certain biologic membranes, right? And this is not just within the GI tract, but we can also talk about things like the breast milk. We can talk about things like different secretions and things like that can potentially concentrate these drugs pretty significantly based on these changes in pH, right? And again, depending on the drug you're dealing with, there may be a weak acid, there may be a weak base. Generally, when you're looking at like drug dosing and things like that, they're already taking into account these different features here. But I kind of wanted you to know like what goes into those decisions and what goes into trying to figure out, hey, should this drug, is it going to be better absorbed in the stomach or not? How do we formulate it to try to make sure that it does have that optimal absorption? You'll probably mention the example of the PPIs, drugs that are unable to be absorbed from the stomach and actually are destroyed by the stomach, that low pH. So we protect them with a little coating, and then once they get into the small intestine, that coating melts away, and then they can be absorbed no problem, right? And remember, when things are in their charged state, they tend to be more polar, right? So they're going to be more water soluble, which can have its benefits in order to get it into solution. But you're going to find it has less lipid solubility, right? And again, sometimes that can be a good thing. So if you're like trying to keep things out of the blood-brain barrier, for instance, you want them to be in that charged state. So I'd probably talked about like our second-generation antihistamines being less sedating because they do have that charge on them, and they're unable to cross over into that into the blood-brain barrier and into the CNS, right? As opposed to like a diphenhydramine or Benadryl or something like that, it can cross over no problem there. So generally, the more charged it is, the less lipid solubility it has. If it's uncharged or neutral, then you're going to see more lipid solubility. And this makes sense when you look at something like sodium, which has a permanent positive charge on there. Once it dissociates from something like chloride in water, how all the negative and positives are sort of lining up with one another in order to increase that solubility, right? And again, if you're a polar bear, that can be a really big problem if you fall off the iceberg and then get into the water there, right? Just kidding. But again, looking at things like aspirin and determining how well it's going to get absorbed depends on that protonation state, right? So remember, when you're in an acidic solution, there's a lot more protons floating around, a lot more hydrogen ions, and so those can then be picked up by these molecules. And in the case of a weak acid, it's going to put it more into this neutral state, which you can see here. Remember, if you add more protons, and on the right side of the equation, it's going to drive it in this direction, and so you're going to have a higher proportion. And again, this is backed up by that Henderson-Hasselbalch equation, which is essentially telling us what the ratio is between the protonated to unprotonated species here. You can see this is going to be much better absorbed in that low pH sort of solution. And then the exact opposite is going to happen with your basic drugs, right? So if you have something like pyrimethamine here, if you put it into a more basic solution, right, something with fewer hydrogen ions, you're going to drive the reaction over in this direction, and you're going to see here there's no charge on this, and so it's going to have an easier time being absorbed. Again, most of this is taken into account when you're looking at drug dosing and whether or not you can give something orally or whether you need to give it rectally or all these different things. But these are some of the factors that go into that, right? So remember that essentially like dissolves like. That's really the big takeaway here, is that weak acids are going to be better dissolved in acidic solutions, are going to be more in that uncharged state. You're going to have weak bases are going to be better off in basic solutions when they're going to have, they're more likely to be in that uncharged state for them, right? So, and again, if you're to look at that pKa of the drug and look at the pH, remember that when those are equal, right? So you have a drug with a pKa of 3.5 and it's at a pH of 3.5, you're going to have a 50-50 split here between the protonated and the unprotonated state. Is by changing that pH, because I can't really do anything about the pK of the drug itself. By changing that pH, though, I can either drive it in one direction or the other in terms of making it more or less soluble and more or less likely to be absorbed through certain membranes, right? So, and again, if you're looking at the Henderson-Hasselbalch, if you rearrange it, again, you're just looking at that difference here between the pK and the pH, and that will tell you roughly that ratio here between the protonated and the unprotonated. Again, just make sure you know this, so that weak acids are going to be more lipid soluble at acidic pH, weak bases are more lipid soluble at alkaline pH. If you got this down, that's 95% of it, okay? So anyway, in seeing how this can affect drug elimination, this can be really important too, as I mentioned, with things either being excreted more quickly or slower, and by changing the actual pH of the urine itself, right? So for instance, we're going to see that weak bases typically are excreted faster in acidic urine. So you're thinking, okay, why would that be? Well, because if it's in acidic urine, it's going to be more so in a charged state, and so that's going to be preventing it from being reabsorbed across the renal tubule, right? And on the other hand, though, we can see that weak acids are excreted faster in alkalotic urine because more of it's in that charged state because it strips off that proton when you have a pH in the urine of like 8 versus it would be if it was down to like 5.5 or something, right? And again, I do this all the time when I have aspirin overdoses. Not me personally having aspirin overdoses, but if I have a patient who I'm consulted on, and they have, they're starting to see some of the classic signs of aspirin overdose, they're starting to see the tachypnea, they're starting to see the sweating and the fever. I know they're in the wrong direction, right? I can see the levels that are high. What we can do is alkalize that urine by giving them sodium bicarb that raises the pH up, and it prevents that aspirin that gets filtered through the glomerulus from being reabsorbed because it's in that charged state. So that's a good thing to help increase elimination that much faster, right? So remember, normally urine's mildly acidic, but that bicarb can be really useful to help and to alkalize it. Now, again, we're never really going to give things to try to acidify the urine, but that's something that we can see, depending on what the pH of the body is in relation to that, and it gets a little more complicated. You hear a lot about that, and I'm sure you did a little bit in physio, but certainly in CMS, you're going to run into that quite a bit as well. But like you can imagine here, sodium bicarb, what would the effect of renal excretion be on a weak acid such as phenobarb? This is another one. This is a anti-epileptic drug or seizure medication that I can administer to that can be overdosed upon, and then we will also give that sodium bicarb, and that helps to put it into a more of that charged state and enhance that elimination, right? So let's look at some examples. Let's kind of put together all those concepts that we were talking about from the last lecture to this one here. So let's say we're looking at the beta blocker propranolol, right? So you can use it for a lot of things like tachyarrhythmias. You can use it for hypertension. You can use it for stage fright. Lots of things, right? So let's say, for instance, we have 160 milligrams. We're taking 1 tab PO daily here, and let's say that looking at the absorption, we see that propranolol is a weak base, but it's highly lipophilic. It has a pK of about 9.4. So you're looking at it and saying, okay, well, is this going to have good absorption or bad absorption? Well, it's a weak base. So if you were to imagine, okay, well, how much of it would be absorbed in the stomach? Well, probably not a lot, right? Because with the pH of the stomach being 2, you're going to see this pKa is going to be much higher than that pH, which means you're going to be putting it into a much more protonated state. And because it's a weak base, it's going to have a positive charge. You're probably not going to get much absorption from the stomach. But once it gets in the small intestine, it starts to raise up and become more basic. That's when you're going to see this lipophilicity really starts to increase, and then you get really good absorption. So propranolol is pretty easy to absorb through. And also with it being really lipophilic, it actually crosses the blood-brain barrier quite easily too, which is why you can see a lot of interesting side effects with propranolol, which we'll get into next semester. But looking at it, we can see if you then look at the first pass effect, and if you recall, that's basically that liver tax that you're paying when a drug comes through from the portal system, from the GI tract, right? And so what we see is that approximately 25% actually reaches systemic circulation. So you can see that 75% of that drug is lost to first pass effect. So the bioavailability is fairly low, even though it's a pretty lipophilic drug, because the liver metabolizes quite a lot of it. So if we were to look at this and say, well, how much of it actually makes it to systemic circulation? Well, it's only 25% of 160. It's only 40 milligrams. And this is another thing too I want you to look at. If the drug you were assigned to has both IV and PO dosing, take a look at the difference between the two there. Sometimes you're going to see it's 1-to-1. Sometimes you're going to see it's quite different, and a lot of this has to do with the bioavailability. In this case here, with this first pass effect, as you might imagine, if I were to give an IV dose of propranolol, it's going to be a lot less than if I were to use a PO dose. Maybe 160 milligrams PO would only be equal to, say, like 40 milligrams IV, for instance, maybe even less than that, right? Because IV has 100% bioavailability. Okay, so you can see some big discrepancies there, and a lot of it has to do with this fact. So let's then say the half-life is approximately 6 hours, right? Remember, that takes it's the time it takes to get down to 50% of that original drug. So let's say, based on the fact that we only have 25% bioavailability, we get 25%, we get 40 milligrams coming through and into the systemic circulation. So if you were to look at the metabolism of the drug, you can see here that, okay, well, at 0 hours, I got 40 milligrams. That's what got absorbed. And based on that 6-hour half-life, I know after 6 hours, it's going to have 20 milligrams left. And after that, it should only have 10 milligrams. And then another 6 hours, I'm going to have 5 milligrams and 2.5. And eventually, you'll have nothing left, right? So again, we're going to kind of combine all these topics together here in just a minute, just so you can kind of get a good feel for it. Well, let's look at the distribution of the drug too, though. So we know what the half-life is. We know it gets, not a super long half-life. Let's look at where the distribution is. What's interesting here is that if you were to look at the protein binding of it, remember, protein binding has a big effect on volume distribution. It actually binds about 90% of it is bound to this alpha-1 acid glycoprotein. So that means that all the stuff in the bloodstream, 90% of it's going to be bound up to that drug, and then 10% of it is free. So if you were to imagine right at hour 0, and that 40 milligrams that comes through, I got 90% of it bound to the drug in the blood, and 4 milligrams, or that 10%, is going to be unbound. One of the key things I want you to remember here too is that unbound drug is the only pharmacologically active fraction. Okay, if something is bound up to the protein, it can't interact with the heart to slow down heart rate. So this is the 4 milligrams is actually the active portion here. Okay, because it's unbound. And again, you can imagine if I were to change how much of this protein is around, I can drastically affect how much is actually bound here. So maybe if I change this from, say, 90 to 80%, because I've gotten rid of some of that protein for whatever reason, maybe due to disease or something, now all of a sudden I got 8 milligrams that's going to be free here. That means you get a doubling of the pharmacologic effect too, right? So again, this can be a big role for drug interactions. Or if I had something else that was also binding to alpha-1 acid glycoprotein, and it was kicking off some of that propranolol to change these percentages, that can have a really big effect on how well the drug is working, sometimes too well, as the case may be. So let's say we're dealing with like a pretty prototypical 70 kilogram male patient here, and they get administered 160 milligrams PO. And again, based off of it having a 25% bioavailability, only 40 milligrams came through. And then let's say right at that time, you went ahead and did a blood level on the patient, okay? Well, I get a concentration of 0.14 milligrams per liter, okay? Well, let's talk about the distribution, right? So one of the things I want you to remember is it was really lipophilic. So even though it does have high protein binding, you're going to find that it is really lipophilic, likes to go into the tissues quite a bit. So we can see here, like, what is the volume distribution in liters for this patient? And then more broadly, if I want to apply this to another patient, what's the liters per kilogram? And so if you recall, dose equals C0 over VD. Or another way we can look at this is C0 by rearranging it is the dose over the VD. I apologize if I misstated that. It should be VD equals dose over C0. But if you rearrange that here, we can see that C0 equals dose over VD. Okay, so we know two of these variables already. So by rearranging this to VD, being dose over C0, you can see what this actually is. So looking at this, I can go ahead and plug this in. So I know my dose was 40 milligrams because that's what was actually bioavailable and actually got through. And I have my C0. I know what my concentration is in this case. And so by actually finding that out, I can actually divide that out and get 286 liters. So that means the apparent volume that you put that 40 milligrams into is like 286 liters. Now, obviously, that patient is not made up of 286 liters. That's a lot of fluid, right? But that's the apparent volume of distribution, right? It's a theoretical sort of number. And if I wanted to figure out the liters per kilogram for this patient here, I would just take that liters and then divide it out by their weight and get 4 liters per kilogram. Okay, so then I could then apply this to a patient of 60 kilograms. I could apply it to a female patient. I could apply it to lots of different things. If you recall, though, when we were looking at volumes of distribution, remember what was that cutoff point between low to high volume of distribution? And it was actually 1 liter per kilogram. Anything less than 1 liter per kilogram has a low volume of distribution and likes to stay in the bloodstream. Anything with a high volume of distribution is going to have anything greater than 1. And it likes to go out into the tissues. So in this case here, you can see the propranolol has a really high volume of distribution. Even though it's highly protein bound, whatever is free and is able to get away from that is going to be distributed out into the tissues, right? And so you can see that can have various effects in terms of the concentration at the tissues, and then things like side effects and stuff that can occur as a result of that. So let's say we want to do a different patient, right? Let's say we have a 50 kilogram female we're dealing with now, and we want to administer 120 milligrams to her, and her volume of distribution is approximately 4 liters per kilogram, right? Which was what we got from that last problem there. So what would her apparent concentration be in the plasma? Right, so what could be her estimated concentration? And again, if you look in the notes section, I believe I put all the information in terms of how to figure this out if I don't put it on the slide itself. But again, if we want to figure out this plasma concentration, and you're like, why would I ever want to know that? Like, who cares what the plasma concentration is? Well, you do care about that because you want to make sure you get a high enough level to become therapeutic, but not so high it causes toxicity. So this is actually a very important concept to understand here. So we got our dose, and we know what the volume distribution is going to be for this patient, so it's very easy to figure out what the C0 should be. And again, this is estimated, and you can then compare it to the actual blood. But this is kind of a prospective way of doing some of our drug dosing. I do this all the time with antibiotics, right? I can figure out specifically what I think is going to be a therapeutic dose for a patient based off of the C0 that I'm shooting for. But going back to this example, remember it's only 25% bioavailability, so of that 120 milligrams, only 30 actually got through, right? So I'm going to use 30 as my dose here, and then I'm going to divide that by the volume distribution for this particular patient. Well, what is that? Well, remember it's that 4 liters per kilogram times her weight of 50 kilograms. So 4 times 50 is 200. So then based on this 30 milligrams divided by 200, which you can see here, she gets a level of 0.15 milligrams per liter. And if you recall, so this is 120 milligrams I gave to this patient to get that level. If you recall, we had a 70 kilogram male we gave 160 milligrams to. It got almost the same level. In that case, it was 0.14. Here's 0.15. So you can see how, based on the size of the patient, you can modify the dose in order to get the same concentration here, right? And it's not rocket science, it's basic algebra. But again, I wanted to illustrate the point and how we can use this in a clinical sort of sense. So let's put it all together. Let's say, for instance, we have a drug we're going to call sarcastanol, right? So it's going to be used to treat excessive sarcasm, which I don't know anyone who has that problem, right? But let's say we're doing this, and it's a weak acid and has a pKa of 5.4. So you think, okay, well, where would it be like absorbed really well at? Well, if it's a weak acid, pKa of 5.4, if I put it into the stomach, it's going to have a pH of 2. I'm going to have a lot of that in the protonated state. It's going to be uncharged because it's a weak acid, and then it's going to have pretty good absorption. So you might see good absorption in the stomach, but maybe poor absorption in the small intestine, for instance, right? And then looking at this, the bioavailability is only about 90%. So for every 10 milligrams I put in there, only 9 are going to get through. So you basically have a 10% liver tax there, and it has a volume distribution of 0.2 liters per kilogram, right? So 0.2 liters per kilogram is less than 1. So I know this is a low volume distribution drug, and it's going to likely want to stay in the central circulation as opposed to out in the tissues, right? So, and then we're dosing at 500 milligrams every 6 hours. I get to my next slide. So let's say after a 500 milligram dose, how much of it would get absorbed into the systemic circulation? Well, we said it's going to be 90% bioavailable. So we do 90% times that 500, and you're going to get 450 milligrams out. So you can see the oral route's pretty good if I'm getting 90% of it actually being absorbed there. So that's fairly good bioavailability. Okay. Now we can see that what effect do you think would have if I were to give the patient a basic drug like calcium carbonate, which is an antacid, right? Meaning it's neutralizing acid in the stomach to prevent things like heartburn. What would that have on its absorption? Well, I said it would probably be pretty well absorbed in something like the stomach where the pH is like 2, and you're keeping a lot of it in that protonated uncharged state because it's a weak acid. Well, if I gave a base and I were to increase the pH of the stomach there, now I'm going to start to favor more of that charged state, right? Because I'm getting rid of some of those hydrogen ions because they're being bound up with this calcium carbonate. So as that pH rises, you're going to see that the bioavailability might actually be lesser. You may actually see that less of it gets absorbed, and so maybe it goes from like 90% down to like 70%, for instance, right? So you can see how this may prevent the drug from really working as well because it's just not getting absorbed there, okay? And if you're not following along with me, just let me know and I can go over some of these things over again, okay? So don't worry about that. So let's say we were given 500 milligram dose to a 70 kilogram male, okay? Well, what would be the expected serum concentration that I would get with that, okay? Well, remember, our dose is going to be what's actually bioavailable, so it's going to be 90% times this 500, so it's going to be 450 milligrams, right? And then it's going to be over my VD. Well, what was my VD? If if you recall, and then again, this is in the notes section, it was 0.2 liters per kilogram. And I'm dealing with a 70 kilogram male, so by putting that in, 0.2 times 70, I'm going to get 14 liters. And no, I don't have all this memorized. Actually, I just have it on a sticky note on my other monitor here, but it's 14 liters, right? And you can see that down at the bottom too. So just taking that 450 divided by that 14 liters, you can get your C0, which actually ends up being 32.14 milligrams per liter. So then I could reference that back to therapeutic concentration and say, okay, well, what's therapeutic? What's the lower end of that to make sure the drug is working? And then what's the high end of that to make sure I don't end up developing a lot of toxicity, okay? And then if you were to imagine that, if you compare like the serum concentrations with something like, this says we have a low volume distribution. If you notice, the level we got was 32 milligrams per liter, as compared to something like Propanol, which had a very high volume distribution. You're only getting like 0.15, 0.14 milligrams per liter. You can see how those drug levels kind of show you like where the drug is really going. If it's not in the blood to measure, because it's not in the tissues, then you're going to get a much lower serum concentration, which is fine. This is part of the features of the drug, and you'll see that reflected in a therapeutic range if one is available for a particular drug. Okay. So hopefully that makes some sense. The last section here I'd like to go over, and this is going to be important when you're doing the drug dosing quiz that I have available. And I'll talk more about that as I finish this section up here. But let's talk about basic dosing conversions and calculations. I know everyone's like super excited about this because this is really just the most interesting thing in the world. But it's basic, and you need to be able to know how to do it. And one of the things I think I unfairly assumed about everyone coming into the program is that they would have kind of a working knowledge of some of these things. I kind of assumed everyone was on the same page, and sometimes that's not the case. So if you know all this stuff already, I apologize if it's a review, but I think these are things that are important to make sure you have down at a baseline when you're doing conversions, and this will apply to other courses too, not just mine. Okay, but requirements for successful mathematical skills in medicine: can you do basic algebra? If yes, you may pass go. You may collect your $200. If not, then we may need to work on that a little bit, and I have a whole quiz just for you to do that. So let's talk about our metric system. In the U.S. we're a little backwards in more ways than one, but we're going to say here that we're in medicine, we're dealing mostly with the metric system. And again, you notice your common sort of prefixes here are going to denote sort of the units we're dealing with. So understand the difference between like a deciliter versus a centiliter and a milliliter in terms of where the decimal place is in terms of where the actual numbers are, because there are cases where you actually have to be able to convert between these different units here. That's really important. I'll show you some examples of this. But let's start off with kind of common units that we're using. The first one is going to be weight. As most of you know, we're going to be dealing with patients in kilograms for the most part, right? A kilogram is 1,000 grams, and so gram is going to be the base unit here, right? What are some other common ones we're going to be using? It's going to be milligrams, which is going to be 1/1000th of a gram. And then we're going to have micrograms here, which you may see many drugs being dosed in as being 1/1,000,000th of a gram, right? So it takes 1,000,000 micrograms to end up equaling 1 gram, and 1,000 milligrams to be 1 gram. And so just giving examples of some common conversions here, say for instance you're working in the NICU and they're reporting out a patient weighing 1,500 grams. It's a premature infant there. So oftentimes my dosing that I have, and you'll see this too when you're looking at your assigned drugs, is that things may be dosed in milligrams per kilogram. And so I can't multiply that milligrams per kilogram times this number, because then I'm going to get way too big of a dose. I have to make sure I'm converting this over and make sure I'm moving my decimal place. So if I have grams here and I'm trying to convert it to kilograms, which is the standard way to weigh most patients, you got to move that decimal place over 3 times. And so now I know this patient weighs 1.5 kilograms. Now I can do my my appropriate drug dosing for that given patient. Here's another example. Here's a drug called Clonidine. We use a lot for hypertension. There's some other indications too, but it is frequently dosed at 0.3 milligrams. Okay, and to be able to convert that to micrograms, because maybe you're dosing it in mics per kilo, for instance, that would then convert over to 300. Right, so moving from milligrams to micrograms, I just have to convert this over by moving the decimal place over 1, 2, and 3 spots. Right. So just keep track of kind of what you're converting from and to, and make sure you're moving the appropriate number of decimal places there. Or say, for instance, I have gabapentin, and you may find someone who's on 3,600 milligrams. If I want to convert that over to grams to get their total amount they're taking in a day, then again, from milli to grams, I can just move it over 1, 2, and 3, and then boom, 3.6 grams. Again, pretty basic stuff, but it's something that I find some patients or some people will have some challenges with if they don't do it frequently. So make sure you can have a good feel for how you're converting these things between one another. In terms of weight, again, this is another really big sticking point you're going to run into, because most of you probably don't know what you weigh in kilograms, but you likely know what you weigh in pounds, right? And so this is a very frequent conversion. This is a good one you want to know. So 1 kilogram equals 2.2 pounds. Okay, and then another thing that's really frustrating when you're dealing with like infants that are just born is they always talk about how much they weigh in pounds and then in ounces. I don't know why they do that. They should just, I don't need to tell my kids 7 pounds, 6 ounces or something like that. Just tell me how many pounds they are, right? But 1 pound is going to be equal to 16 ounces, okay? So being able to convert between these is really handy because, again, if I have, say, an infant coming in to the ER and they're in cardiac arrest and I have to be able to dose a drug like epinephrine in, milligrams per kilogram, but the parents come in the state, they weigh 8 pounds and 6 ounces, I better be able to convert that over pretty quick, because otherwise that patient is going to be delayed in getting their medication, and that may prevent them from being successfully resuscitated, right? So here's a few examples here. So common conversions, 164-pound person. Well, how do I get from pounds to kilograms? Basically, all you have to do, it's because of this conversion here, I divide the number of pounds by 2.2, and that's going to end up being my kilogram amount, right? And so again, you can imagine if a patient is not being dosed appropriately, or say someone enters in their weight as pounds, but the field read kilograms, you can see how that could lead to some pretty significant dosing errors, right? Sometimes I have to call down to the ER, and they'll have a patient who, something like, 12-year-old who weighs 100 kilograms. I'm like, wait a second, are you sure you didn't put in pounds as kilograms? And they're like, no, the patient just happens to be obese, right? There are some cases where that is appropriate, but it's always good to double check yourself, right? On the other hand, though, if I wanted to go from kilograms to pounds, then I just multiply by 2.2. Okay, so 115 kilograms to 2.2, multiply that by 2.2 and you get 253 pounds here, right? And so here, if you want to imagine, okay, well, I have a 6-pound, 4-ounce infant, how do I convert that to kilograms if I needed to dose that child very quickly in milligrams per kilogram, for instance? Well, 6 pounds, basically figure out how many pounds is represented by this ounces here. So I know there's 16 ounces in 1 pound. So 4 divided by 16, that's a quarter of a pound, so 0.25. So 6.25 pounds. Then I go ahead and divide that by 2.2, and then now I know this kid weighs roughly 2.84 kilograms, and now I can dose off of that. Almost everything you're going to run into is dosing off of kilograms. So get into a habit of being able to convert pounds over to kilograms, not in your head necessarily, but at least know what that conversion factor is. So moving to length, you won't see length used too often in at least in medication and pharmacology, things like that, but it does come up occasionally. So like imagine we're doing dosing of a patient off of the body surface area, and I need to factor in their height. If I only know their height in feet and inches, I have to be able to convert that over to centimeters, right? And so these are handy things to be able to know about that. So again, a meter is the base unit here. A centimeter is just going to be 1/100th of that, and then a millimeter being 1/1000th, right? So 1 centimeter is equal to 10 millimeters, which makes sense based on this conversion here. And then 1 inch is another handy conversion to know. It won't come up as often as the pounds to kilos, but 1 inch is equal to 2.54 centimeters, right? So for example, some common conversions, I know there's 12 inches in a foot. So if I have someone who's 5'11", then I can say, okay, well, it's 11, and then I know there's 12 inches for every foot, so 12 times 5 gives me 60, and then plus that 11, a 71-inch patient. I can then convert that over to centimeters by multiplying that by 2.54, okay? Or if I was doing like a 3-centimeter laceration, if I want to estimate how much that was in inches, because most patients don't know, most American patients at least, don't really have a good sense for what a centimeter is. If you want to convert it over to inches, you just take this and divide it by 2.54, and then you get your 1.2 inches roughly, okay? Again, if this doesn't make any sense, let me know. Don't feel embarrassed about that. I'm more than happy to go over it in more detail. Volume is very important, especially when we're talking about dealing with dosing liquid medications, especially. You'll see this come up all the time, basically. We're going to see 1 liter is going to be the base unit, and then a milliliter is going to be roughly 1,000th of that. So 1 milliliter is 1,000 of those. 1,000 milliliters is 1 liter of fluids. Most of you probably know that, but again, just to state the points here. If you ever see someone talk about 3 cc's of fluids or give them 100 cc's of this, that stands for 1 cubic centimeter, which is equal to 1 ml. I generally talk in mLs. Some people still say cc's, but it doesn't really make a difference as long as you understand that one is equal to the other. Okay. This is important too when we're starting to get into talking about drug dosing or like dispense amounts and things like that. 1 ounce is equal to 30 mLs, right? So 30 mLs is equal to 1 ounce, and then 1 cup is 8 ounces. Okay, so it's important to understand those conversions there. Even more important than that is talking about teaspoons and tablespoons. This is because in the past, this is a frequent way for dosing things. So you'd say give 2 teaspoons 4 times a day. The inherent problems with using teaspoons, though, are the fact that not all spoons are created equal, and they are not designed to measure exact amounts. And so, for instance, if I go over to IKEA and I buy a Swedish spoon, it may not actually measure the same, a Swedish teaspoon, it may not measure the same amount as when I get from Walmart as an American teaspoon, right? Actually, I have a few IKEA spoons and they're all shaped a little differently, so I've not actually measured them out, but I imagine they are not exact. But 1 teaspoon means 5 mLs, and then 1 tablespoon equals 15 mLs. So, for instance, you can see that 2 tablespoons equals 1 ounce, right? And again, being able to convert all those back over to mLs is very important, so that way you can be very exact. Nowadays, we don't dose off of teaspoons and tablespoons because people get that confused all the time. If you can convert everything over into mLs, that'll be very handy because that's much more exact, and we have things like dosing syringes now to make sure we're giving people the right amount that they need. Some common volume conversions you can see here. So for instance, like half a liter is equal to 500 mLs. Again, you're just moving over 3 spots, so you get 500 mLs there. If I was to give someone 6 ounces of fluid, or if I was doing, say, feeds for an infant, 6 ounces of fluids, well, 6 times 30 mLs per ounce, I know they're getting 180 mLs, right? 4 teaspoons, I know there's 5 mLs per every teaspoon, so 5 times 4 is 20. And then for, say I had 60 mLs, how many tablespoons would that be? Well, I know there's 15 mLs per tablespoon, and so I can just divide that by 15, and I get 4 tablespoons. This would be an uncommon conversion, but sometimes you may have like a patient comes in and they say, I'll give my kid 2 tablespoons of this stuff. And you're like, well, how much is that? Well, you can convert it over to mLs now because there's for every tablespoon there's 15 mLs, right? So fairly straightforward. And you'll see things like, it expresses concentrations all the time. And so this is why it's good to have an understanding of how to convert these if need be, and how to actually calculate how much volume you have to give based off of a given dose of a medication. So, for instance, if I have a patient who's actively coding, so they're in cardiac arrest, and you say, go ahead and give the patient 0.2 milligrams of epinephrine, that nurse doesn't care what the dose is. She needs to know how much volume that 0.2 milligrams equals, and this is where the concentrations really come into play. So this is another good concept to be familiar with. So let's say we have a drug that's in a liquid form. As I mentioned, it's listed in its concentrations. For instance, like with oral suspensions, you'll see this quite a bit. Amoxicillin, 400 milligrams per 5 mLs. Or acetaminophen, 160 milligrams per 5 mLs. Why do they do per 5 mLs? Because everything used to be dosed in teaspoons, and so that's why this is sort of an anachronistic sort of thing, but it's still listed that way. Or let's say I was doing, I had some IV fluids, right? And so I'm looking at some of these IV medications like dopamine, 1600 micrograms per ml, or morphine, 2 milligrams per ml, intravenous solution, right? This is good to know because if I have a dose I want to give, if I want to give 5 milligrams of morphine, and I have a 2 milligram per ml concentration, I need to be able to convert that over to figure out how many mLs I'm going to inject that patient with, right? If you screw it up, you give too much, patient's going to sedate. If you don't give them enough, they're going to be in pain. So you want to make sure you don't do either of those. And then frequently for fluids, this would be an example of IV fluids you might give a patient. So it's listed as 0.9% sodium chloride. We're going to learn that this is normal saline, and 5% dextrose with 20 MEQs per liter of KCl, right? This is a pretty standard maintenance fluid you might give to a patient on the floor, for instance. So if you ever hear like D5NS with 20, that's what they're kind of referring to, is these concentrations of each of the components here you would find in the bag of fluids you have in front of you, right? So let's go through some examples of drug dosing calculations. I kind of want to start easy and then work our way up. And so again, if you look in the notes section, you're going to be able to find all of the calculations there, so you can follow along with me. One of the biggest things that I can tell you though is to follow your units and make sure everything is canceling out until you get to the final thing you want to know, right? So for instance here, I have an adult patient who's in pain and they require ibuprofen 600 milligrams by mouth. And I have 200 milligram tablets available. How many tablets should the patient get? And again, you're like, Dr. Wood, are you kidding me? Like, this is brain dead simple. Again, it'll get more complicated, so just wait. So again, what am I starting with? I know I have 600 milligrams I need to give the patient. What am I ultimately asking though? How many tablets should they get? So at the very end, everything should cancel out and I should be left with the number of tablets needed, right? So I think I have it on the next slide here. So if I have 600 milligrams times 1 tablet per 200 milligrams, well, I know that the milligrams are going to cancel out here. So 600 tablets over 200, I know that cancels out to 3 tablets, okay? And again, most of you probably did that in your head, but this is the long form process of it. And make sure you're going to be canceling out all of those units. This is important because if you can do it for this, then you can do it for the more complicated ones where it may become more difficult, right? And again, I'm going to use the pen here a little bit, and you're going to see how bad my handwriting is when dealing with a left-handed person using a right-handed mouse to write with. So it's going to get pretty abstract here in terms of art, but hopefully you can follow along with me, especially what's down in the bottom there. So let's say, for instance, we have a 20 kilogram child who's diagnosed with influenza A, and you're going to prescribe them oseltamivir or Tamiflu, 6 milligrams per ml oral suspension, and they're going to get 45 milligrams twice daily. How many mLs will they require per dose? So again, what am I ultimately asking at the very end? You should come up with mLs per dose, right? So how would I go ahead and go about doing that? Okay, well, I start out, I know a patient needs to get 45 milligrams. Let's see. And again, this is going to be very bad, but you can follow on the bottom. Per dose, right? Boy, I'm really poor handwriting. But so you have 400 milligrams, 45 milligrams, so they're going to be getting per dose there, right? And so what I'm going to say is that, okay, well, I know my concentration. So let's say that I know that the solution that I'm using, the suspension, is that for every 1 ml, I'm going to be getting 6 milligrams, right? I mean, I know that based off of this is 6 milligrams per ml. So I just did the inverse there, and 1 ml is over 6 milligrams, okay? So what cancels out here? Well, the milligrams are going to start to cancel out, and so I know I'm going to get 45 mLs divided by 6, so it's going to equal 45 mLs. Remember, I still have that per dose there, and so 6 doses. Oh my goodness, this is ridiculous. I think I got to do that S backwards there, so you can probably see my dyslexia popping up. And then I can divide that out, and basically I'm going to end up getting, I'm going to get 7.5 mLs per dose. Right? So 7.5 mL. So that's how much the patient's actually going to be getting. Because you could tell the patient, hey, go ahead and give your kid 45 milligrams twice daily. And they're like, well, how much is that supposed to equal out to be? You have to make sure you tell them that, because it's much easier to tell someone, take 7.5 mLs, or if you want to convert it back, you could say 1.5 teaspoons. They're going to be getting twice a day, right? In total, they're going to get 15 mLs per day, right? That's another way I could have asked, how many mLs per day should they get? Or I could tell you the number of days they're going to take, and I say, okay, well, for that prescription, what's the total dispense amount you're going to need? So if I know they're going to be on it for 5 days, and I know they're taking 15 mLs a day, then I can do 15 times 5 and get the total amount that would need to be dispensed for that patient. That's good to write on their prescriptions, as you'll see. We talk about that a little bit later, right? So let's do a little bit more complicated, right? So that was fairly straightforward. Let's say we have a 25 kilo patient who is prescribed amoxicillin, 80 milligrams per ml, oral suspension, and they're getting 45 mg per kilo twice daily. How many mLs should that patient get per dose? Okay, well, how much should they get? Well, and actually, I might just type this out, because this will be probably easier in the long run than you trying to follow my poor handwriting here. So basically what I'm going to start out with is I need to figure out, like, what's the actual dose this patient needs to get here, right? So I know that they're a 25 kilo patient, and they're getting 45 mg per kilo twice daily, right? So I can sort of go ahead and say that we're going to get 25 kilograms. Again, obviously my typing is pretty bad too, because my microphone's right in front of here. But I'm going to say 25 kilograms. I'm going to multiply that by 45 milligrams per kilogram, right? So my kilograms are going to cancel out, and I'm going to get my total actual amount of drug they should be getting per dose. So I should be getting 1125 milligrams per dose that they're going to be getting there, right? So 1125 milligrams per dose. So that's good to know. Now I need to figure out, though, how do I convert that over into the number of mLs they're going to need to get that dose, right? So I know I need 1125 milligrams in total, and I'm going to multiply that by the concentration of the drug. So it's 80 milligrams per ml, but I want to convert that over and figure out how many mLs they need. So I know for every 1 ml, they're getting 80 milligrams, right? So that 80 milligrams is going to cancel out the milligrams in the dose I actually need to give the patient. And so ultimately what I find out is I'm going to end up needing 14 mLs per dose, right? Or I can even put over here, I can say per dose. So as long as you keep the units straight and you can cancel all that stuff out, you're going to be good to go, right? And again, always figure out, what am I asking for at the very end here? I need to know mLs per dose. How many mLs should the patient receive per dose? That's what you want to know, okay? So it get a little more complicated because in the previous example, the dose was given to you. You already knew the patient needed 45 milligrams per dose. Here you had to figure that out based off the size of the patient. So you had this one extra step that was involved there, right? Okay, so, and then let's say we wanted to get a little more complicated. So this is probably even probably the most complicated one we're going to get into, at least in terms of this one here. So let's say we have a patient who is 64 kilograms and they're going to receive a dopamine infusion. Let's say they have sepsis and their blood pressure's low, their heart rate's low. We need to get that back up, right? And so we're going to start them off at 10 mics per kilo per minute of dopamine, and it comes as a 1.6 milligram per ml intravenous solution. So how many mLs per hour will this patient require? And again, this is a common thing that pops up if you say you're working in the ER or the ICU, for instance, and the nurse is like, well, how much do I need to give, right? Because it's always better to have two people do the calculations independently to make sure that everything is right. So maybe the nurse figured out a rate that she thinks the patient should get. You should be able to figure it out too, to make sure that those are actually matching up, right? So you're thinking, okay, well, I got so much information here, kind of where do I start? Where do I even begin with? Well, first off, I want to figure out, like, what is the actual dose that is going to be required for this patient here? Like, actually, how much do they need to get? And so I can start off by saying, okay, well, I know they're getting 10 mics per kilo per minute. I know they're 64 kilograms. I can already see one spot where I can start to cancel some stuff out, right? So I can go ahead and say that they're 64 kilograms, and then I'm going to multiply that by that 10 mics per kilogram per dose, right? So now what do I have here? Well, the kilogram should be canceling out at this point. I'm sorry, I don't know if I can make my font any bigger here, so hopefully you guys can view that. But let's say 64 kilograms times 10 mics per kilo per dose. What am I going to get? Well, it's basically going to equal out to be 640 micrograms per minute, right? And you also notice the problem here too is that I was asking how many they're going to get per hour. So don't worry, we'll do that conversion too. It's just another step in the process, right? And so I know that my available concentration that I have is 1.6 milligrams per ml. But I'm working with micrograms here, right? So I need to make sure that I do that conversion too. So 1.6 milligrams per ml, if I wanted to convert that over, I could basically just multiply that by 1,000 micrograms per every 1 milligram, and I can basically turn that into that it's a 1,600 microgram per ml concentration, okay? So again, now I'm taking that extra step and I've made sure everything is in the correct units now, right? So if I want to figure out how much they're going to get in a volume per minute, which would be the next step, because the last thing I had here was minutes, I know they're getting 640 micrograms per minute, and then I'm going to multiply that by my concentration, which is for every 1 ml, I have 1,600 micrograms, right? So what does that equal out to? Well, 640, so if you notice here too, the micrograms cancel out, and all it should be left with is mLs per minute. So I get 0.4 mLs per minute. So now I have an actual rate that I can give to the patient. And then the last step is to figure out, well, how many mLs per hour they're going to be getting, right? This is important. I do this a lot too, to make sure that we are sending the nurses the right appropriate volume. So if something's running at 500 mLs an hour, I'm not going to send them a 25 ml syringe. That would be ridiculous. I want to send them enough to run for many hours. So let's say I want to figure out how many mLs per hour they're going to get. Well, I know they're getting 0.4 mLs per minute. And you guys probably know the next step I'm going to do here. Multiply that by 60 minutes for every 1 hour. And so essentially you're going to find is the minutes will end up canceling out, and so they're going to equal out to be 24 mLs per hour. So as long as you're doing it on a step-by-step process here, and you're making sure that you are following your units, you're figuring out specifically what I'm asking for, and then kind of analyzing and determining, okay, what are the given information I have, and how am I going to turn that into what he's actually asking for at the end? And so that's kind of what we're doing here. And it's a pretty straightforward process, but if you haven't done it before, you don't even know really how to think about it to come up with a means of coming up with a solution. So that's why I kind of covered it here, to make sure you at least have sort of the thought process down. You kind of see where we're going from step to step. So always follow your units and really, really read to make sure you see exactly what's being asked for at the end there. Because again, you may come up with a totally different thing that no one really cares about, or no one really needs to know at that point. Always convert everything back into metrics. So for instance, if I give you a patient's weight in pounds, make sure always convert it back into kilograms, right? You can just take that and divide by 2.2 and convert it back into mLs, all that good stuff, because that's how most things are going to be dosed for the most part. And then when in doubt, your local pharmacists are always very bribable, typically either appealing to their ego or monetary remuneration. All of those things are perfectly fine, and they can help you out too. A lot of times you're going to find that by having this sort of trifecta of the team between the provider, the pharmacist, and the nurse, they all can kind of work together to make sure that the dosing is correct, and we're figuring out how to actually get it to the patient in terms of what we have available, like with IV solutions and all that kind of stuff, right? So, see, sending them a sandwich via the tube system. That's interesting. I don't know how well a sandwich would hold up. I've not tried to send a sandwich in the tube system before. I wonder if you put them all in separate, like kept them as separate from one another. If you put it through the tube, if they all kind of like came up as a final sandwich, that'd be kind of interesting to see. But so that's it for this section here. The one thing I wanted to show you is that you have a quiz to do in your class here. So let me see. And I think I closed out my window that I wanted, but that's okay. Those dry turkey sandwiches really get people going. Yeah, don't do dry turkey sandwiches. Maybe like a nice a Reuben or something. That'd be good. Okay, so I'm going to show you. Do we solve problems like these on the exam? If so, we'll be able to have scratch paper. You're always. Oh man, Publix is probably the greatest subs of all time. That's definitely the best way to bribe at least this pharmacist here. Looking at this, it was an Uncrustable, so step by step and only a little, maybe, yeah. Okay, so check out your drug dosing calculation quiz here. This will be due on the, what date did I set this due to? It'll be due on July 24th. So it'll be due at the same time as your drug information assignment. And so basically what I want you to do is be able to take this quiz. You will have as many times as you like. You can repeat this as many times. You'll see which ones you got wrong when you're done with it. But I want you to be able to do these type of calculations. So the question came up is, do you need to do this for the exam? No, this is why I do the quiz here now, to make sure that you get a chance to practice, and it's okay if you're wrong, because you can go ahead and be wrong multiple times until you kind of get the concept down. So I will not put calculation like this on the test, so don't worry about that. Yeah, so that should answer that question. So let's see if there are any questions on the sticky board. Okay, let's see here. Someone wrote, for common adverse reactions, my drug has many that indicate 3 to 9%, but not higher than 10%. So I just select any 3. Yeah, if that's the case there, you can select a couple of them and just put kind of the more common things. Sometimes, too, in Lexicomp, it'll break it down by different body systems. And so you may want to pick, like, the top ones out of, like, a couple of different systems. So you can say, like, sedation from the CNS section, and then myalgias from the musculoskeletal, etc. So those are the kind of things I would expect you to be able to pick up for that assignment there. A lot of people were asking, too, they were saying, okay, well, it says my drug has no known metabolism. What do I put there? That's okay. Like, some drugs don't get metabolized. They actually just go excreted from the kidneys unchanged, right? You should still be able to kind of notate that, though, and say, like, okay, well, what impacts might that have if I had someone like poor kidney function, right? There's probably like another question for that, for instance. But that's okay. Just make sure you at least address it and say, I wouldn't just put NA. That kind of shows me you probably didn't look it up, but you can at least say, hey, there's no known metabolism that we know about currently, right? Okay, so yeah, that was a quick one. We're done a little early. Any other questions that I can answer for you guys? Again, I apologize about the technical issues, but it is what it is. We're in COVID time, so hopefully we'll have a little bit of grace there and not trash my my evals too much. based off of that. But if nothing else, you guys are free to go, and I will see you. Let's see, I'm trying to think when our next meeting is. Might be tomorrow, actually. At least tomorrow. Yep, no problem. I will see you guys then, and have a great afternoon, evening, and night.